So it's such a great honor to host you for our last evening webinar of the week. But we still have a masterclass on Saturday on the interpretation of chest x-rays, which I have shared with you there in the chat. I am not alone. I am with Dr. Zinzile Ngwenyama. Hi, Zinzi. Welcome to the clinical care platform. You can just say hi so that colleagues can hear your voice.
Hi, Leseho, and thanks for having me.
Thank you. Thank you. A warm welcome. And we are so grateful to host you here at the platform. Colleagues, let us welcome Dr. Zinzi with an applaud. Please send her lots of hugs and hearts and because this is day one and we know that we always appreciate those who take time to add value in our lives, and we don't take any second of their time for granted. So we really, really treasure this moment. Let me share my usual slides so that I can take you through a couple of updates before we can start. I actually want to, can I just see a few seconds? I want to also allow those who are joining us on the other, I think it's this one. Let me see. Yeah, I think they'll be able to see. Yeah. So just a couple of slides introductory. I'm going to run very quickly. Today we are focusing on the children and we are looking at heart failure in children. We hope that no child gets to experience such a medical condition, but these things do happen. Therefore, me and you, we always have to be ready. Hence, this topic aligns very closely with our mission, which is to improve patient care. For today, is to improve pediatric care, and most of us are not very comfortable managing children. So I hope that at least after in an hour's time, your confidence in this component of cardiology would be elevated. So we are a membership-based platform. Our events remain open until the end of September. I think my team announced that from October we'll be serving our members. We'll see how that goes. But anyway, if you have joined us today and you'd like to get administrative support, CPDs, and reporting to council, you have to be a member. It costs 3 rands per day, which is 1,200 rands for a 12 months kind of a program. Our diploma preparatory programs are open for registration: HIV, internal medicine, obstetrics, and child health. You can see that we have also added 2 more, anesthesia and also ophthalmology. So if you are interested in any of these, I did share the link earlier on. I'll share it again towards the end of today's webinar. To our members, you now have an additional 10 micro lessons which are CPD accredited. All you need to do is to log in onto the platform and enjoy yourself. If you are interested in some of our paid programs, self-paced e-learning, we do have a dispensing course. We do have some specialty programs in nephrology, cardiology, endocrinology, HIV medicine. So just check out these on our website. And if you would love to join, I think it's easy. We are a virtual platform. Don't miss the chest x-ray masterclass happening this Saturday. It's adult focused, right? Yesterday there was a question, what about children? We will plan something on pediatric radiology. I think there's Prof Nazrin who believes that she can do it for us. So I'll keep you updated on how that is going. And yes, if you are in Durban, KZN, we are coming your way on the 25th of October. We have a boot camp on the fine needle aspiration. We had a hugely successful one last year in Johannesburg, and I know that the Durbanites, our KwaZulu Natal people, will make it to be a success. But let me stop and just to appreciate this incredible moment to officially host Dr. Zinzile Ngwenyama on a very important topic of heart failure in children. And just to tell you a little bit about her, because it's the first day, so I'm going to read the profile. You know, we don't usually read that detail, but she is a qualified pediatric cardiologist who completed her subspecialty with the University of Cape Town. She currently currently practices in Mpumalanga in both public and the private sector, Robs Ferreira, Kiat, and Mediclinic. She obtained her undergraduate qualification from UKZN, Babu Pibagit, and completed her postgraduate training in pediatrics with the University of Free State. So with her comprehensive training, and you can see how she practices, she's going to bring her expertise to the people of Mpumalanga. But for us today, we are so grateful because we are going to be super, 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 super empowered. So I'm very, very happy about this. Yeah, can I hand over to you, Dr. Zinzile, Dr. Ngwenyama? You may share your slides, and then after that, you can say hi to colleagues, and then we can start. Thank you. Lots of hearts. Yeah, it's coming through, Doc. We're about to see it. Yes, we can see your slides in full screen. Yep, it's full on my side, and I'm hoping it's presenter mode on your side. You may unmute and take us through. Thanks, Doc.
Okay. Good evening, everyone. Thanks, Lesego, for having me. As introduced, I am Zinzile Ngwenyama. So today we are going to do heart failure in children. I do not have any disclosures, no conflict of interest. So heart failure is defined as a complex clinical syndrome with signs and symptoms that results from any structural or functional impairment of ventricular filling or ejection of blood. This then leads to circulatory, neurohormonal, and molecular abnormalities. And then, obviously, in severe cases, you then lose cardiac output and circulatory collapse. The causes are numerous. They range from volume overload. It actually depends how you want to look at it, but I like putting things into groups. So heart failure causes can be congenital and acquired. As you can see, the causes are numerous, and you have volume overloaded lesions. These are left to right shunts from a large VSD, a PDA, AVSD, AP window. AP window, for those that don't know, it's a connection between a pulmonary artery and an ascending AO, and then you're getting a left to right shunt from the AO to the pulmonary artery, and you get pressure-loaded lesions, which are obstructive lesions, whether on the right side or left side, with aortic stenosis and coarctation causing heart failure. You also have complex cardiac lesions like a single ventricle, hypoplastic and hypoplastic heart, as well as TGA. These are common, especially TGA, causing heart failure in children, especially in infants, in neonates, and infancy. And then you have causes from a normal, like a normal structural heart, especially dilated cardiomyopathy, which is the most common cause of myopathy, of heart failure in those patients that have a normal heart. And obviously you have other cardiomyopathies like hypertrophic cardiomyopathy and restrictive cardiomyopathy, but those are not common, but they can cause heart failure. And then you have lesions that causes heart failure from abnormal rhythms, so, things like arrhythmogenic cardiomyopathies. These, if treat the arrhythmia, then it will then cause heart failure. Then you have another category called secondary. I mentioned it. I'm calling it secondary because it's an insult that happens either congenitally or acquired. These toxins that can affect, which I'll show you later, what toxins are imported. But ischemia, that's very common, where you have a viral infection, then causes Kawasaki disease, especially adeno, and then that causes heart failure. And then Al-Kappa is an ischemic heart disease, which actually a congenital abnormality where your coronary is not connected from, it's not coming from the left coronary, it's actually coming from it's connected to the pulmonary artery. So it's actually abnormal left coronary artery from the pulmonary artery. So you're actually getting blood that is deoxygenated initially, but later on you're getting collaterals that supplies the left ventricular capillary bed. And therefore, because you're getting a steal of blood going into the pulmonary artery later on, then the left ventricular bed gets ischemic, hence the patient will present in heart failure. And then you have infections that can cause heart failure, also post-op lesions that can cause to try and meet metabolic demands. However, because it's ongoing untreated cardiac injury, then you'll have poor ventricular function to causing heart failure, which in turn will lead to decreased stroke volume and cardiac output. So because of the heart failure that that the child now has, then it will then present as cardiac dysfunction, hemodynamic decompensation, manifesting as increased preload and afterload, and also you get decreased cardiac output. Because you're getting decreased cardiac output, then you have decreased renal perfusion, and obviously your baroreceptors stimulation will also be affected, which then will lead to activation of sympathetic nervous system to try and compensate for the poor cardiac function, where your heart rate will go up, and as well as your contractility will also go up. Excuse me. In combination, you have a RAS system, which occurs where you have a hypotension, therefore you have decreased renal perfusion, then the kidneys will try and release renin, which then will release angiotensinogen, which then converts angiotensin 1 to angiotensin 2 via the angiotensin converting enzyme, which your angiotensin 2 is important in vasoconstricting, in making sure that the aldosterone is produced, which then will cause sodium and fluid retention. So aldosterone will then bind to the distal tubules and collecting duct, and that causes sodium resorption, potassium secretion, vascular remodeling, and stiffness, and then it will then increase cardiac inflammation, fibrosis, and remodeling. So this is the end results, because obviously the aldosterone is produced where you get myocardial hypertrophy, myocyte hypertrophy, as well as apoptosis, and you have myocardial fibrosis, which then results in chamber dilatation, decreased cardiac function, and then worsens failure, which then will lead to death if untreated. So how do these children present? I have grouped it into two, where in infancy, they may present with poor feeding. Others will present, like I said, in Al-Kappa, they will present with, whenever they feed, they cry. It's because of the ischemic event that they are getting. As well as you look at their road to head chart, and they crossing centers, they might present with recurrent chest infection, especially if it's a left to right lesion, and therefore then you actually having increased pulmonary blood flow into the lungs. And they present with diaphoresis, which is sweating while feeding, and difficulty finishing feeds, as well as tachypnea. All the children will present differently, but the symptoms usually overlap. As you can see, edema, it's not really mentioned in infancy because they usually, if present, you will see periorbital edema, but basically in all the children, they'll have pedal edema and signs of right heart failure. In terms of examination, you want to make sure that you examine all systems that are involved. In this case, you need to make sure that the child is not in cardiogenic shock. So you will have to look at the perfusion. Is the child perfusing well, as well as whether there is any weak thready pulse. And if that's the case, then you need to make, and the BP is low, then you need to make sure that you start inotropes. Is the child having edema, and is there any distended neck veins? And then in terms of respiratory, like I said, they present with respiratory distress. You might find wheezing in children, and it can be difficult to tease out bronchiolitis versus cardiac failure. But remember, with especially because with bronchiolitis, then you have a displaced liver or enlarged, falsely enlarged liver. But then you have to tie up all the signs, because with heart failure, obviously your apex will be displaced, as well as you have other things like a tachycardia, your liver, and the x-ray will also help you out in the ECG. So in terms of CVS, like I had said, you have to make sure that, well, you look for signs of tachycardia. Is the child tachycardic, and why are they tachycardic? Is it because of heart failure, or is it because they're in shock, or is it because of any other cause of the tachycardia? Maybe the electrolytes are also deranged. Then you do the blood pressure, which can be high or low. So if it's obstructive cause of the heart failure, then you can get hypertensive cardiomyopathy. So it's important to actually make sure that you monitor the BP and make sure that you find out why is the patient hypertensive, because that will give you the cause of the hypertension. Obviously, if the child is hypotensive, then it's more of a shock-like state. You look for a Gallup reading at all times. Like I said, displays apex and a heave. And in infancy, a heave, you need to look, you have to feel for epigastric pulsation just below the xiphisternum. And the hepatomegaly must be quantified. And as you treat the patient, you have to feel the liver, whether it's decreasing in size or not. In terms of investigations, as you put up a drip, you have to make sure that you do a blood gas, because that at least tells you about the metabolic state of the patient, the electrolytes, the sugar, and then things that you can correct, you correct immediately. And then in terms of bloods, normal bloods, FBC, because you want to know whether the child is anemic or not, and if anemic, what's the cause? Because iron is important in assessing with cardiac function. So if the child is anemic, especially iron deficient, you might need to add iron as part of your management. And in terms of you, and also you do a UNE, the urea and creatinine, as we have said, that you get renal hypoperfusion, your urea will go up, and you also, as well as creatinine. But many a times your urea is higher than obviously your creatinine in terms of normal ranges. Many a times your creatinine remains normal, but it can be slightly high. So if your urea is high, don't be alarmed. Let's say the urea is 9 and the creatinine is normal, and the child needs Lasix. Please give it, but we'll talk about that later. And then your LFTs is important because you want to know whether your hepatic enzymes have increased or not. Remember, you're having a decreased cardiac output state, and therefore you are not perfusing the liver. That's number one. Number two, because of the heart function that's not functioning optimally, you're having a backflow, like congestion into the liver. Hence, your hepatic enzymes will also increase. So you want to know where you start. I always want to exclude an infection. So it's a good start to do a blood culture and an NPA if you are able to do viral studies. This is a nasopharyngeal aspirate. At the start of your management, especially if it's a normal heart, like a dilated cardiomyopathy, you want to know the pro-BNP at the start of your management, but then later on, just to see if it's coming down. Remember, pro-BNP gets released with chamber dilatation. And then you want to do a chest X-ray without showing a ECG, echo, and sometimes we might need to do a cath, which we really do. So this is an ECG of a patient that, actually this is a common occurrence where you're having a patient coming in with such ECG and you don't really know what to do. You can see there's P wave, the child is tachycardic, and because the child is about 4 years of age, there is positive T waves there in V1 that signifies RVH. But of note that I actually want to point out with this ECG is that you're getting overlapping of these QRS's complexes, and then that is called a Katzvachtel phenomenon.
Hi,
That
Doc.
usually, hello?
Yeah, feel free to use your mouse cursor just to show the areas you are referring to. I don't know if you can move it around and see
Okay,
if
sorry.
people can see. Yeah, sure. Thanks.
Okay, so because you have overlapping of your QRSs, it tells you that there is biventricular hypertrophy. It's a phenomenon called Katzvachtel phenomenon. Sorry if I'm not saying it correctly, but you can Google it. So that tells you that both ventricles are actually dilated. And with this, in order for you need to decrease the scale to at least 5. Usually we use a 10 millimeter scale. You can decrease it to 5, but remember when you do that, you must make sure that you multiply your number by 2. Remember the criteria for LVH is when you add your R wave. I mean, let's start for RVH. First is your T wave that's positive in V1 in a child that's older than 7 days of life. And then you add your R wave plus your S wave in V6 or V5. That total, if it's more than 35, then you say that there's R. But LVH, then positive wave to R wave in V6, S wave in V1 in combination, if that makes you 35, sorry, the RVH is 25, sorry about that. So if that's the case, then you can diagnose LVH and RVH. I hope it's clear. And then this is the chest X-ray that you usually get where you're getting massive cardiomegaly. If you look closely, somewhere there, you see that somewhere there. These are not really, you are seeing the infiltrative changes, but this is pleura, where the vessel has edema around it. So you have to give a Lasix in order to decrease the congestion in the lungs. And then I wanted to also show you that, so if you look at the echo, this is a modified view. Everyone can see that this heart is not pumping correctly. It's the function is poor. So you can see the way this and that, you see this valve and that valve is moving faster with greater strength as opposed to this one that's very slow. So if you see this, I think you also need to look at normal echoes. But if you see this, this tells you that there is poor cardiac function, then the child will warrant like a proper screening echo. And then in terms of, in terms of management, so I have grouped it into acute and chronic management. So in terms of acute, also divided into two, where you will start with the non-pharmacological management. This instance, I don't like fluids. Everyone, we don't like fluids, all of us cardiologists, because you can actually make things worse. It can cause the child can die. So try and fluid restrict as much as possible. Don't try and avoid IV fluids for all cardiac patients. And ask the dietitian to increase caloric intake. They are there to assist you to measure goal. We call it goal feeds for the patient. That will help you with management of the congestion. And every single day, you need to weigh the patient, especially if you are dealing with a patient that came in that has anasaka or edema and or a liver that's on the floor. You have to weigh the patient. As the patient loses weight, that tells you that the patient is actually getting better. And in terms of ventilation, please do not use higher oxygen, higher than 30%, because oxygen is a vasodilator. The more oxygen you give, the more you flood the lungs, and then you actually gonna chase your tail, and you're not going to win with the heart failure. So keep sets as low as 85 and above, especially for the left to right shunts. You do not want to vasodilate those pulmonary arteries and cause further insult into the lungs. You need to treat any anemia, because anemia worsens cardiac failure, and iron is important, like I said, in cardiac function. So give iron supplements if the level is low. Obviously, you have to transfuse if the HP is less than 10, or clinically the child is not well. And then you treat any infections, you correct electrolytes. Usually, I would make sure that your calcium, your magnesium, and your phosphate are all corrected, because that helps you with cardiac function, especially your calcium and your magnesium. And in terms of your ventilation, again, sorry, I forgot that you need to make sure that you at least try CPAP first, because that will reduce the afterload on the left ventricle, and therefore it will help with cardiac function, because you remember you're having a failing heart. But obviously, if CPAP fails, you have to intubate. And if you don't have CPAP, you intubate. And then, like I said, blood pressure control is very important, whether it's hypertensive or hypotensive. You have to restrict the salt, but that will also do it with the dietitian. In terms of medication that you have to give, the first medication is Lasix. We give 1 milligram per kg, depending on how bad the status is. If the patient is in overt failure, you can give 6 hourly, but otherwise 8 hourly BD is fine. We try and avoid to use it long term, but many a times we end up giving it anyway. We also have to give spironolactone, which helps with the remodeling of the heart. We do give anticoagulation, especially in patients that have a clot, or if the ejection fraction is less than 30. And then you consider giving any of the anticoagulation, whether aspirin or warfarin, but that you have to discuss with the cardiologist. And then captopril, the goal is to go into 1 milligram per kg 8 hourly. And then inotropes, which I would suggest that we look into the vitamin and milneuron, which will help you with myocardial contractility and improve cardiac output. And then you want to know how these drugs work. You know, Lasix will inhibit the sodium potassium chloride co-transporter. It works actually here in the ascending loop of Henle. It causes sodium chloride and potassium to be excreted in the urine. It has a half-life of 3 hours. Lasix is a very good drug. It's available everywhere. So it's unfortunately can sometimes taper with your urea, but don't be scared. And now you want to stop diuretics because the urea is high. However, if the creatinine now start climbing, you need to be really careful. And then in terms of the other drugs, spironolactone, because it's a potassium sparing, it's always nice to give it with Lasix, but it also has, it blocks the aldosterone receptor mediated action. Like we said, that aldosterone causes remodeling myocyte and my apoptosis as well. And it has a half-life, of 1.4 hours. The side effects are many. You notice that I didn't mention diazide, but we do use it on very rare cases later on, but not so much. We usually use the loop diuretics, which is the Lasix. The side effects, mainly the electrolyte abnormalities like your hypocalcemia, hypokalemia, hypomagnesemia, the urea going up, as well as it can cause toxicity when given very fast via IV. So you have to be very careful with that. And then the spiral, usually hyperkalemia, metabolic acidosis are common. Those are the two that we commonly see. But yeah, especially if your sodium, your potassium is a problem, you might need to adjust either Lasix or spiral, either stop the one or the other, because your Lasix drops your potassium and your spiral increases your potassium. So if your potassium is high, you might just need to stop the spiral and leave the Lasix and allow the potassium to adjust. And then in terms of the ACEs, as we have mentioned, that it blocks the angiotensin 1 from converting into angiotensin 2. It's a very good drug. And it usually helps. It's like an afterload reducing agent, and therefore it helps with LV with systemic vasodilatation as well. And the side effect, the main ones that we see is dry cough and angioedema. Some people will say that don't give it in asthmatic, which is true. Then we will have to then use another drug. And then the main other effect that we see with this is hypotension. That's why we don't start the dose at a higher dose, like 1 milligram. We start at a very, very low dose, just a testing dose. Sometimes we even go 0.5 milligrams 8 hourly, irrespective of the age, just to do a test dose, and then we gradually go up until we reach target dosages. And then how do you decide in terms of inotropic support? So you have to look at the patient and decide whether is a patient the perfusion is, does the patient feel warm, and in terms of congestion, are they edematous? Because if that's the case, then you have to use diuretics. And if the patient is cold and dry, then you start inotropes. And if the patient is warm and dry, then that's the goal. You've reached your goal in terms of acute management. And therefore, you will then have to try and start stabilization therapy. Excuse me. So with stabilization therapy, you must make sure that the child is adequately supported in terms of respiratory. You might need to call a cardiologist who will then call electrophysiologists who will help you with any patient that has pre-excited dilated cardiomyopathy, which is associated with mechanical dysynchrony, which then will then worsen the ventricular remodeling, and therefore sometimes the patient will then need ablation, because the more the dysynchrony continues, then the cardiac output is being lost. Remember, the coronary perfusion is in diastole. So if you have dysynchrony or arrhythmia, then you do not allow ventricular filling. And if you don't do that, then you will lose cardiac output and the patient will die. This is a goal. This is what you want to achieve. These are the drugs that you want to put the patient on, which is a beta blocker, sorry. A beta blocker, like I said, you want to decrease the heart rate to allow ventricular filling. We have this drug in South Africa and it's been used, and it's a goal. It's the one of those drugs that you start after you have started your Lasix spiral captopro beta blocker, and then you have to use an ARNI, which helps with, it has both RAS properties. So it also helps with remodeling, and as well as your spiral, like I said. This is a new drug that's being introduced, I think last year or the year, yeah, it was last year. It is good for chronic, it's a chronic diuretic. It is also used in endocrine. It also regulate glucose, but its side effects is hypoglycemia. So that's why the endocrinologists don't like it that much. There's other adjuvant therapy that you can use. In this case, you have an option of putting a ventricular assist device. This, I'll show you now how it looks like. And then you can do ECMO just in the interim, waiting for a heart transplant. Sometimes these patients, there's no cure, or like you can't do any heart surgery, especially if it's dilated cardiomyopathy, because it affects the heart muscle. So they need a cardiac transplant, but sometimes they don't qualify for a cardiac transplant, and hence then you then have to opt out for palliative care. I hope I'm not too fast. And then in terms of, I just wanted to show you this ventricular assist device. So what the surgeons will do is put in this device. There's different types. So they will put in the LV, and then that is the generator, and then it will bypass, and the other cannula will be connected into the AO. And then this monitor has this cable that comes out of the patient, and then has this system control and the battery life. How it works is when the blood comes back from LA, it will go into LV. So instead of LV pumping, or well, it can pump, it will pump the blood, but because it's left ventricular dysfunction, most of the blood will be sucked in or pulled into this monitor, such that the LV has less work to do, and then you will then go into the AO and blood will be pumped into the system. This is usually done in children that are waiting to have a cardiac transplant. It's a very good device to have, especially if you can't transplant or waiting for a transplant and you have a patient that can afford to pay for it. I'm not sure if medical aid pays for such things. There's stages of heart failure and potential therapies. You get a stage A and B, which a patient is not symptomatic. There are patients that presents like that. They are fine, they're okay, maybe they have a lower respiratory tract infection, then you find them in failure. And that those two, you will just give ACE and beta blockers. They should be fine, they should be okay. However, stage C and D is those ones that will need like cardiac review, at least a cardiologist, because those ones, they either need surgery or they will need a transplant. In that case, that's when you will put in a ventricular assist device, or you transplant them, or an ECMO, and then they will need to go into chronic therapy. So cardiac failure, you have to work with the rehab team, because you can't work in isolation. You need everyone on board, the dietitian, to make sure that there's caloric intake, it's been taken care of, and it's been measured every single day, and the patient is getting enough. And OT and physio, just to make sure that the patient is mobilizing. Social worker, make sure that there's grant that is being secured, as well as social well-being and food security is important, because you do not want to discharge a patient home and they don't have food. So a social worker must make sure that there is someone that's working at home. You need to have a good relationship with your colleagues, especially your pediatrician and a pediatric cardiologist. In terms of chronic management, like I said, all 4 drugs are standard medication. Lasix, as you can see, is not part of chronic med, but sometimes we are pushed to use it. So actually this drug, this new guy, DAPA, is actually sort of like replacing Lasix. So as soon as you put them on this drug, then they actually need less Lasix, because this is a very potent diuretic. You will see that other units, well, where I was trained, we never use much of the of digoxin for cardiac failure. Other units, they still use digoxin, which is good. However, you must be careful with digoxin, because you have to make sure that there is no electrolyte abnormalities, especially your potassium, which can cause digoxin toxicity. And metallazone is also used for diuretic resistant cases, where the child is on Lasix and maybe on DAPA, and you're still not getting the on top of the failure. Then you can use like a set dose, but it must be used as an inpatient setting, in an inpatient setting, sorry. Then you have an option of using acetazolamide. We use it. I know most people use it for respiratory alkalosis, especially the intensivist, but in cardiac failure it can be used. We usually will give a dose for 3 days, 8 hourly. That helps as a diuretic as well. Sorry, Entresto is, like I said, it has two properties, where your valsartan is your angiotensin receptor blocker, and sacubitril is a nepralizing inhibitor, which then promotes sodium and water excretion. I think Lesego will know this drug better, sacubitril, because it's a ARV. So in terms of new therapies, this you don't need to know, but it's nice to know. Someone is laughing at you, Lesego.
I'm also laughing and
Ivabrine
very scared. I'm like, ooh, me.
sorry. So ivabrine is another drug that we can give, but we usually avoid giving it because obviously of side effects. But basically what it does, if your beta blocker doesn't work, then you can use it, especially for those that have arrhythmia-induced heart failure. You might need to consider it, but the guideline says if you're not dropping your heart rate with beta blocker, you must use ivabrine. And Vericiguat is still under trial. So, but it's nice to know that we still have other drugs that that are in the pipeline. In terms of follow-up plan, like I said, stage A and B, those are asymptomatic. You can, they even elongate it to 6 to 12 months. But the ones that I'm worried about is stage C and D, which you need to see every 3 to 6 months, where you'll have to do an ECG just to make sure that they're in sinus. You do an echo, you do a pro-BNP. We don't really routinely do exercise testing for heart failure, but we should, but we don't usually have the capacity to do so. But it's actually nice to know how the patient copes, especially at school. Are they playing sports? If they are playing sports, then it's nice to do exercise straight. But if they are not playing sport, it will be difficult actually for them to be on the treadmill. And then in terms of, I just wanted to mention briefly about dilated cardiomyopathy, because that's the most common cause of heart failure in children, especially in normal structural hearts. I hope the slides projects well, but the causes are numerous. So it's very important, excuse me, to know the causes, especially because many a times we don't know the cause. It's idiopathic. So it can be divided into primary and secondary causes. Primary is usually genetic causes. Secondary causes, it can be toxin, your iron, your lead, your cobalt, your anything that's a problem. But I just want to zoom into this section, because viral infection is actually common, especially your adeno, your parvovirus. Those two causes dilated cardiomyopathy. And it's so sad because these children, the cardiac function to return back to normal, sometimes it doesn't, and we don't have enough hearts to do transplant for all of them. And these are rare ones. I think the viral ones are more common. Sometimes we just call it a myocarditis, hoping that the patient's the heart function will recover. I look at this article and I was like, interesting. So there are other causes of dilated cardiomyopathy, especially for the teenagers that are starting to vape, and then they are coming into casualties. They are drunk, and you give them ketamine, which damages the heart. I thought this is interesting for me, as well as cannabis. Cannabis is very, very notorious in causing a lot of problems. But this, I just put it in, especially for obviously not for the young ones, obviously the teenagers that comes to you, and they have a history of either substance abuse or mainly substance abuse, and as well as caffeine. So this is just letting you know that we also need to just ask about substance in children, especially teenagers, which will then tell you whether there is any insult or not, risk factor per se. And then for those that are interested, I just put this slide just to show the workup that we do for a dilated cardiomyopathy. You see, it's lengthy. It's bloods that you have to take, all the echoes, the chest X-ray, the ECG. I didn't add, but this is just blood workup, excluding everything that I've mentioned that side, all the causes, just to make sure that everything is fine. Many a times we don't have a cause. Unfortunately, we don't have money to do genetic testing in our children, especially in the public sector. I think the test cost about 12,000 and it's done overseas. So if the parents can afford, then sure, you can do it. But basically, we are unable to do the test. That's why sometimes we say idiopathic cardiomyopathy. Take home message, I think, is important. ABC, treat the shock, start diuretics as early as possible. If unsure, call us. Don't use any fluids. Avoid any IV fluids. No fluid. Notice I said no fluid boluses. I know many a times you're like, the child is in shock, fluid boluses. I'm sorry, I also did it. But that was wrong. Now I know better. I don't do it. And
Mm. Oh, I've unmuted.
and then
Sorry.
multidisciplinary. Yeah, multidisciplinary team, and always ask questions. It's important, if you don't understand as a young doctor, to always ask. I know my MO always says, but I don't know what to ask. But just ask something, yeah. And then now, before I say no, if anyone can tell me about this ECG, then we are done.
Okay.
What they
Okay.
see and
Colleagues, feel free to type in the chat, but we would love one of you to just raise your hand and try it. Give us a live answer. ECGs, and I know we haven't done pediatric ECG, pediatric chest X-ray. So now I feel like, my people are not ready. Yes, but we have the diplomats here.
it's fine.
Yeah, hi, let's
But I
see.
see someone is laughing, someone is celebrating, so there must be an answer somewhere.
Yeah, don't give us an answer yet, Doc. Colleagues, a volunteer, feel free to raise your hand. I will give you the mic. Otherwise, do type in the chat and then I will read as well. I would really love us to give it a try. What do you think is happening there? Prudence says LVH, left ventricular hypertrophy. K says narrow complex. Is it touchy? I'm saying tachycardia, twitchy. I don't know. TWCHW,
Yeah,
overlapping QRS
I think they should have
complexes,
asked me.
biventricular
Yes,
hypertrophy. Yeah.
yes.
Mary says both,
I
right
think
and
they should
left.
have asked me about the age. So this is a 6-week-old
6 week
presenting
old.
in failure, and then you see this.
Yeah. Yo,
But they
shame.
are on
Six
the
week.
right track.
Yeah, bilateral ventricular hypertrophy. That's Netemba. Bantu says left ventricular. So others are choosing left, others are saying right, others are saying both. And then David is like me, we just hit it general CCF. Yeah, but CCF is a clinical one. It's a clinical assessment. At least if I call you, I'll say the patient has CCF. All right. Yeah, I think it's the same trend,
Okay, I
either
think
left,
the
right, or
ones that
both.
said
Yeah.
okay, the ones that said both is correct. You can see there's positive there, negative there. There's also T wave that are positive there. So that's RVH for that, and then LVH is this which you need to measure properly using a proper scale. Remember, I said you have to cut it down to 5. But the reason why I've put this is because I wanted to show you. In lead 1, look at this Q wave there.
Hi, Doc.
Okay. Hello.
Can we do it? Can you exit the presenter mode? Because when you point, Zoom is pointing at the corner, not necessarily where the problem is. So
Okay.
I thought you were going to go back to those 3 dots and just say slide mode, but it's fine. Where are you now?
Oh, sorry. Me, I
It's okay.
am
Yeah, just put it on.
EPT.
Yeah, put it yeah, just full screen. Don't do presenter mode on your side so that where you are pointing, it's also what we see. Yeah, awesome.
Can you see it now?
Yes, you can start explaining from the start. Thanks. Yeah.
Okay. So we'll do, hopefully we'll do ECGs, but basically you can see it's tachycardia. And the one thing I wanted to show you on this slide is that the Q wave in lead 1 and Q wave in AVR, you can see that that's deep. If you see that in lead 1 and AVL, sorry, then that tells you, and dilatation of the chambers, that with ST elevation or depression, that tells you that the child has Al Kappa. I did mention briefly about that earlier on, where I said the coronary artery that's supposed to be connecting from the aorta is now connecting from the pulmonary artery. So you're getting a bypass of blood from, so you're getting RCA supplying the right ventricle. But because the left ventricle doesn't have oxygenated blood, then you're getting a bypass of blood from RCA through the coronaries through into the pulmonary arteries, bypassing the LV bed. That's why the child has ischemia and therefore will present in failure. I hope I tried to summarize. So that's the Al Kappa I was talking about earlier.
Awesome.
Okay.
Awesome.
Thank you. Any questions?
Awesome. Thank you so much, Dr. Zinzi. I think, yeah, hey, I miss medical school.
We can't hear you.
Oh, am I? Oh yeah, I've muted.
Let's
Oh
see.
yeah. I was just appreciating and saying thank you so much. You remind me of medical school. And yeah, colleagues, how was it? We've been very thin on pediatric topics, and I did promise the colleagues that we will do our best to bring them up. And we have started on a high note. I hope you are appreciating this opportunity. Dr. Zinzi's video is off. Let me play a video to remind you of what's coming, and then we'll take just 10 minutes for some of the questions.
Welcome to the Chest X-ray Interpretation Masterclass, a physician's perspective information session. If you've ever found yourself looking at a chest X-ray and second-guessing your interpretation, you're not alone. Despite being one of the most commonly ordered imaging studies, many clinicians lack confidence in reading them. This session is designed to give you a structured, practical approach to chest X-ray interpretation, from assessing image quality to systematically reviewing PA and lateral views, and identifying key pathologies like airspace disease, interstitial patterns, bronchiectasis, cardiac failure, and pleural disease. Let's explore how you can sharpen your interpretation skills and apply this knowledge directly in your clinical practice. Thanks for joining us. Let's get started.
To understand what we are looking at, we need to firstly understand what an
Awesome. Dr. Zinzi, are you able to hear me? Because I noticed that your video went off. I'm not sure if you are still here. And I don't see your mic sign.
I am here.
Oh, okay. No, that's fine because I wanted to. So let me start with my question, and then we have like 20 questions to go through. So let's see how much. I just wanted to check with you in terms of access for these children. I mean, what's your sense? Do you feel like there's good access for children who have cardiac issues? Do we have enough cardiologists? Do these kids present on time? I mean, what is your experience around? Do you see them when it's too late, where you can't do much? Or yeah, I don't know what your experience around access for cardiology services. Yeah.
I recently started in RAPS, so
Yeah.
it's difficult. I think late referral is a problem,
Yeah.
especially from the clinic side. I think we need to educate even the sisters how to recognize cardiac failure, because then they will refer more. I mean, a child shouldn't be crossing centiles. We should be looking for a cause why the child is crossing. I mean, I recently had a patient that was referred by a dietitian to say that the child has a heart problem, and actually the child had a double articulate, a right ventricle, and a TGA, which the sisters had missed so many times, and it's sad.
Yeah, hence me asking, because as you're presenting, I was just trying to think whether these kids, we are able to identify them timely, because usually when they cross centers, we're always thinking food. Mommy, you're not feeding the child, but maybe the clinical evaluation is not done optimally. So Prudence says, I'm also in Mpumalanga and I'm from UKZN and I'm specializing in pediatrics. I'm looking up to you, Z. So you have a fan.
Yay! All the best.
So Brandon, I know, is in the diploma child health, is probably going for the OSCEs in the next few weeks, and he's saying, can you please explain when to use prostaglandins and what a PDA dependent, or what is a PDA dependent lesion? Hey, yeah, he's asking you exam questions. What is a SMA syndrome, and how will one do pre and post ductal sets? Obviously, he's going for the exam. I know, Brendan. So he's trying.
Yeah, he's scanning.
He's
I
asking for
see
your
all the
help.
best.
He's asking for your help. Yeah.
Okay, I think the first question was, when will you use prostate? So it's you use it for PDA dependent lesions. It will be like your TGA. It will be like obviously your extreme TETs. So that is your PAVSDs, because you want pulmonary blood flow. If there's no forward flow into the lungs, or there is no mixing in terms of a TGA, then you will use it. You will also use it in critical pulmonary stenosis. You will also use it in critical aortic stenosis. The PDA is actually, you actually want to try and get blood flowing from the AO to the pulmonary artery and then going to the systemic circulation. If you have an atretic pulmonary artery, then you're not getting any blood going forward into the pulmonary artery. So you have to have another way of getting blood into the lungs, which a PDA will help in this case. Previously, we'll jump into doing a shunt for them, but we have other options now. You have depending on the lesion, you can do a stent of the PDA. You can have an RVOT stenting as well. Then a shunt as well is an option, or just go straight into correcting the problem. I think that was the.
Yeah,
Did
that
I
was the
address
main
all
question.
questions?
Maybe how will one do the pre and post saturations? I think is trying to figure out how to get the correct saturation. Is it sets, right? I see sets there on the last one.
Yes.
Yeah.
So I usually would use the right hand and the right foot and see the difference. Obviously, if the difference is more than 10%, you're thinking pulmonary hypertension, PPHN, but there's sometimes differential sets. Be careful with that, because sometimes you have differential sets where your lower limb set is higher than your upper limb set. Be careful, because you might miss it. It's something like a TGA.
Awesome. Brendan, don't worry. I spoke to Zinzi. We are trying to do something for the diploma guys, and I'm hoping that we pull it off. Yeah. So yeah. Let's keep looking at it. Magito says, I really like Doc, the way you have explained this complex approach. You make it very fun. Oh, I didn't know that cardiology can be fun. All those ECGs. Prudence says
Thank you.
for right and left. Oh, you want to comment on Magito's comment? Did I cut you?
No, thank you so much.
Welcome. Prudence is talking about both left and right ventricular hypertrophy. Says, can we use 35 and 25 across all age groups, or your targets, your ranges are age dependent? I think that's what she's trying to assess. Can we use those numbers for all age groups?
Yes. So you have to use lower sets. Ideally, use a blender, which we don't have in Mpumalanga. Lord have mercy. But just convince your medical managers to buy you a blender. We are in 2025. We have to regulate the oxygen. You can't give oxygen directly from the wall, because you don't know how much oxygen you are giving to the patient. So you have to regulate it. We need blenders for every child that's on oxygen. You need to regulate it using a blender. Even if they buy 4 of them, it's enough. And especially for cardiac patients, please use a blender. Or even if it's high flow, at least high flow has some numbers there. Then you regulate it. Give anything less than 30%. The flow can be high, that's fine, because that helps with positive pressure ventilation. But the FiO2 that you're giving, it has to be less than 30%. Ideally 21%. But that is very important, because especially for the left to right shunt, like I said, you dilating your pulmonary arteries, and therefore you worsening the failure. And the child will not be out of failure, because you keep on making things worse. And you ask yourself, why is this child in refractory heart failure? It's because of some of the things that we do.
Awesome. And then, Doc, regarding the formulas that you used, remember on the ECG strip, you did mention that for right ventricular hypertrophy, we must add this and this and this. And if it's more than 35, this is what it means. That formula applies for all age groups.
Yes.
Okay.
It does.
Okay. Awesome. Makito is back. Hopefully, we will be expecting you in the child health. Hey, yeah, you are being committed, Doc. Okay, this we addressed. Sorry, I think I must just go straight to the
I ask a lot of questions. They must be careful. My emos knows, and they are here. So
Yeah, but it's in progress, colleagues. I've seen many comments about this. It's in progress. Anonymous, maybe it's your MO doesn't want you to see them. Says ACTZ versus furosemide in neonates. Which one is better to treat in this age group? If ACTZ, when do we switch to furosemide in later infancy? So maybe the choice between the two, how do you go about it?
okay, so I like respecting colleagues. I know the neonates, they like HCTZ. So I'm happy with that. But after a month, uh, after the neonatal period, Lasix is also fine. Or at discharge, you can use it. The Lasix, change it to Lasix. Because I know the reason why they like ACTZ versus, Lasix in neonates. So I don't mind either or, it works for us. We actually okay with everything, and it works the same. However, at discharge, it's actually better to actually give them Lasix because it also comes with in a syrup form. So at least they can actually give it nicely at home.
Okay. Awesome. Tembela then is asking, can we use enalapril if we don't have captopril? And when is sildenafil used in pits? Is there a place for sildenafil?
Okay. So for enalapril, we do use it. I actually, for chronic medication, I would opt out for, enalapril because it's given BD. But these are children that are older. I usually, like more than 5 years, I will start them on enalapril because they're now going to school. So you actually want to make sure that they don't miss their dosages. But before that, it's fine. Captopril should work okay. And then in terms of sildenafil, PPHN, we do give sildenafil. Any patient that has pulmonary hypertension, which we quantify, and we would suggest that start sildenafil on certain patients. Then we'll also give sildenafil. It's a tricky drug, especially for PPHN, because it can drop the BP so rapidly. So you have to be careful. Start slow. 0.5 milligram per kg, gradually work your way up. Maximum dose is 1 milligrams per kg, 8 hourly or 6 hourly, depending on how bad the pulmonary pressures are.
Awesome. Tembela, I hope you are sorted. How common is the cough from ACE inhibitors in children? Is it something you have experienced, and how have you approached that? I know in
It is,
yeah.
yeah, no, I don't really see it much. Yeah, it's not really common, but especially the ones that have hyperactive airways like asthma background, then you might have to experience that. Yeah. How do I deal with that? Remember I said you can use ACE inhibitor. And then if that doesn't work, or if you want to upscale it, you can use a RNI. And I said an RNI is divided into two classes. So you can actually, instead of using the ACE, you can use a beta blocker and maybe consider an RNI, which will then do the same work that Captopro will have done. So it's also an afterload reducing agent.
Awesome. Case is back. He's asking about prognosis. So that 6-week-old child, the trace that you showed us, what are we looking at in terms of prognosis? But overall, heart failure in children, Can these children be productive adults and get to 50, 60 years?
Okay, it depends on the cause.
Mm.
You've seen I've classified them into different groups.
Mm.
So the left to right chance, if you do say they should be okay, as well as the pressure loaded, so your aortic stenosis and stuff, that should be okay. The normal hearts, that is dilated cardiomyopathy, hypertrophic cardiomyopathy, arrhythmogenic, that depends what is the cause of the dilated cardiomyopathy. And it also depends on, when did it happen. If it's a dilated cardiomyopathy diagnosed at 6 months, for example, the prognosis is bad. If diagnosed at, let's say, 10 years, 11 years of age, the prognosis it's guided, but you have an option of sending the child to do a transplant. So you have that option. Whereas a 6-month-old, you can't transplant.
Okay.
So, and then obviously transplant has 10-year survival rate, and then they need a new heart again. So yeah, that's the thing. And then if it's arrhythmogenic cardiomyopathy, as soon as you correct the arrhythmia, the heart failure resolves. Therefore, the child should be okay.
Okay.
But getting that arrhythmia controlled, Lord have mercy. It's
Yeah, tough.
very tricky.
Tough. It's another prognosis question, and Mongamel is asking if rheumatic heart disease is still a common cause of heart failure in your setting, and how are these kids doing? It was actually an alternate topic, Mongameli, for Dr. Zinzile, but we opted for heart failure. So yeah, yeah.
So I did see a lot of rheumatic hearts in Cape Town. Not really here. Maybe they're not referred. It's possible we are missing them. But usually they do well. The rheumatic heart doesn't really cause overt heart failure. After initial treatment, you end up just giving prophylaxis and they are okay. However, you get those cases where the valve is completely damaged and therefore will then need surgery, where they'll have to have a valve replacement, and because they are in overt or refractory failure. So yeah, it happens, but not common to get a refractory failure with rheumatic hearts.
Thank you. Innocent's question is a bit long, but I can rephrase it and ask you: caffeine and dilated cardiomyopathy and caffeine, and we're talking children. How much caffeine? But I think the way I can rephrase it, like I have kids here, so I'm wondering, should they be drinking coffee, Red Bull, or what? Or they shouldn't be drinking Coke. What's the advice around caffeine and children and the heart?
That article was actually saying they shouldn't, children, I mean, caffeine is an insult to the heart. But I think, I believe children should be children. They should just drink water and juice. That's my personal belief. And because they run around basically, so they get dehydrated. So you need them to take proper fluids, which juice, not too much sugar, like juice and a lot of fluid, a lot of water should be okay for them. Caffeine, I'm not a fan, so I think I'll be biased with the answer. Yeah.
Yeah, no. I'll advise them here at home. Hopefully I win the battle. Chueni says, oh, very interesting. And yeah, I think when you put those two strips, the first one in the slides and at the end, you made us aware that yeah, maybe we need some update or something on ECGs. So Chueni is asking, they hope to have ECG, pediatric ECG soon. Yes, Chueni, I'm hoping with you, and you know, we will try. I think this is covered, right? What other alternative can be used instead of captopril? I think we have covered it very nicely. Prudence, hey, Prudence, Luena, ECG. Yeah. It's knocking on the door. Drycough, Bogekile. People want ECG. Is that last strip, ne? At the end, I think you made us feel like, the last time we saw such a strip,
You don't
it,
know.
it was in medical school. All right, I think there's
No,
just
it's fine.
yeah, sure. Sorry, I'm trying to filter because these ones I had selected. So now, we're gonna take the last two questions, colleagues. 'Cause I think 8 o'clock we must have a hard stop. We are heading towards the coaching programs. We must practice stopping before 8. What is the approach to cardiomyopathy related to malnutrition? Well, give the child nutrition. I don't know. Is there anything else? Yeah.
Yeah. You have to correct the malnutrition.
Mm,
I think which will have electrolyte abnormalities. I think carnitine is also another problem. So that's why I mentioned supplements in my talk.
mm,
So if it's hardly unlikely that the malnutrition is causing cardiomyopathy, but it's possible. But I think if you correct the malnutrition, then everything will correct. Remember, when you have malnutrition, your iron will also drop, your electrolytes will be deranged, the
albumin.
patient has infection.
Mm,
So there's lots of things that you need to correct, and with that correction, I think later on things will be fine.
awesome.
But you can't do it alone, like I said. You have to work as a team with the rehab team.
Awesome. Colleagues are happy. Dr. Zinzi Samsekile says, much appreciated, Doc. Vusmusi, Danke, Maureen, much appreciated. Brendan, remember the first question, the exam question, says thank you. I had forgotten about differential sets. So the impact is huge. Well, Tao Chan is a family physician, and it's a question I had written it down. This because I think we have kids who are wheezing and we are giving them all sorts of pumps. Maybe they have a heart issue. You can see Walter says some kids with heart failure are treated for ongoing pneumonia and those kinds of things. I know you had a slide on symptoms and stuff. I mean, let's say I'm a nurse at PHC or I'm a primary healthcare doctor, I'm a GP. A child is presenting with respiratory symptoms. What are one or two things that if they are in addition to the respiratory symptoms, I should be thinking of the heart? Because even our examination skills for these children, especially the heart, I saw you talk about the hip and what below the sternum. I'm like, doctor. So I don't know. What's your advice? What are we looking at? We'll go back to that slide, but just at the high level to say, don't just think the chest. It could be the heart if there's also 1, 2, 3. Yeah.
Okay, it depends. If you're a sister, it's different from a doctor.
Okay.
But the doctor has said an apex that's displaced.
Mm,
Even if you don't hear the gallop, because the gallop is tricky.
mm,
If in apex that's displaced and the liver that's there, think heart.
okay.
You don't have an X-ray,
Mm,
but I'm sure in a clinic you will be able to access an ECG. Then you see, okay, chambers are dilated, then refer.
okay.
A sister, obviously, if there's the vitals are not good and the child is distressed, they will then have to refer. because I think that's what they are. I think it's IMCI.
Yes, IMCI.
They follow
Yeah.
IMCI. And yes, when IMCI says this, then they have to refer. That is part of red flags that, yeah, if the child is tachycardic or, yeah, low BP,
Awesome.
which they don't do BPs at the clinic as well.
I can give them advice whenever you want to use the red pen to circle that declining graph. That means refer, because the red pen itself is not treatment. Because sometimes you find that
Yeah,
the
so
graph is
funny.
going down, there's this red pen, but the action to refer the child is not being done. I think that is where the issues are. Colleagues, unfortunately, I see all your. Do you know Refilwe? Refilwe is very happy. I don't know if you know Refilwe, but okay, so he's my friend
Yes,
from.
I do. She's a good friend of
Yeah,
mine.
colleagues, it's exactly 8 o'clock. I think I see all the questions. We will see how we navigate a follow-up session. Just to say thank you so much, Doc. Maybe your closing remarks as we call it a day. Thank you.
Yeah, thank you for having me. And I hope this complex lesion I try to explain in simplest form. And for any questions, you can email me. And yeah, because if I give you my number, it's a problem. Not unless I can give you my medical officer's number. And she won't be happy.
Yeah, colleagues. Yeah, it's day one. I think let's give
For
doctors.
any
Yes.
for any referral, don't be scared to contact us.
Yeah.
We are at Rafarera as well as in private. We are also willing to see any of the patients that you are worried about. Yeah.
Yes, the Demba says we will have the number for referrals. It's Netemba, no number. All right, colleagues, I've shared 3 important links in the chat there. Firstly, join the platform, become a member so that we can do more for you. Number 2, the diploma preparatory programs are open for registration. So please do check it out. We have child health, anesthesia, ophthalmology, internal medicine, HIV, obstetrics. We are really trying. And lastly, this weekend, we have the chest x-ray masterclass. On that note, may I wish you a restful night and a great weekend with your families if I'm not going to be seeing you this Saturday. Sharp, sharp. Bye.
In today's fast-paced world, keeping up with the latest medical knowledge can be a challenge, especially for healthcare workers striving to provide the best care possible. Introducing the Clinical Care Platform, a proudly South African, wholly owned online subscription edutech company built for healthcare professionals. Our mission is simple: to improve patient care by increasing access to high-quality, evidence-based educational resources, anywhere, anytime. With our membership subscription, you gain unlimited access to a growing library of over 155 CPD accredited courses, weekly micro lessons, and 10% discount on paid e-learning courses, all curated to align with local and global guidelines. Join live webinars, over 160 sessions and counting, earn CPD points on your schedule, and download key clinical resources, including templates, research reports, and practice guidelines. Subscribe, get educated, earn CPD points. With the Clinical Care Platform, lifelong learning is just a click away.
Missed our latest webinar? No worries. We know life gets busy, but your professional development shouldn't have to wait. That's why we've created webinar micro lessons. Short, focused recaps of our full sessions designed to help you catch up quickly and still earn your CPD points. These bite-sized lessons are available exclusively to active subscribe members. So even if you miss a live session, you never miss out on the knowledge or the CPD points. Not subscribed yet? Now's the perfect time to join. Get access to all future webinars, every micro lesson, and more. Visit www.clinicalcareplatform.com to sign up